Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. So today in this episode, I am going to discuss about pseudocyst of the pancreas. What I am going to do here is an algorithmic approach. I'll be using an algorithm to discuss about the various aspects of the pseudocyst of the pancreas. So after watching this video, all of you should be able to understand the various causes for the epigastric lump. You should know the definition of what is pseudocyst pancreas and what is walled off pancreatic necrosis or WOPN. You should also understand the etiology, clinical features including the symptoms and signs, investigations and treatment of the pseudocyst of the pancreas. Of course, at the end of the presentation, I have included a mind map also. So what are the different causes for the epigastric lump? It could be epigastric or omental hernia, any pancreatic tumor including the pseudocyst, gastric carcinoma, GIST or the gastrointestinal stromal tumors affecting the stomach mainly, and the AAA, that is abdominal aortic aneurysm, any retroperitoneal sarcoma, hepatomegaly, especially the left lobe of the liver. So you must understand some of the definitions in this topic. That is actually it is called walled off pancreatic collections. So that involves two things. One is the pseudocyst of the pancreas, and another one is the walled off pancreatic necrosis. What is pseudocyst of the pancreas? This is a round or oval, thin-walled swelling that contains only liquid. Yeah, there is no solid element here, and it is homogeneous. And usually it is extra pancreatic. There won't be any connection between the cyst and the pancreatic duct, usually. Whereas the WOPN or the walled off pancreatic necrosis is a well encapsulated collection of liquid and solid debris and necrosis, and this is having a heterogeneous appearance. This may be sometimes multilocular also. So coming to the etiology of pseudocyst of the pancreas, this could be because of acute pancreatitis, chronic pancreatitis, or trauma to the pancreas. So these can be classified into four types, the walled off collections. It could be acute peripancreatic collection, or if it is less than 4 weeks duration, eventually it will turn into pseudocyst if it lasts for more than 4 weeks. So what is acute peripancreatic collection? That means it is less than 4 weeks duration. It happens in interstitial pancreatitis and it is homogeneous in appearance. That means it is only fluid and no fully defined cyst wall is there. It is adjacent to the pancreas and it is confined by the normal facial planes. Usually the collection is in the lesser sac. Whereas pseudocyst, usually if the acute peripancreatic collection lasts for more than 4 weeks, then it is called pseudocyst of the pancreas. This also results from interstitial pancreatitis. This is also homogeneous and containing only fluid. But here you can see a well-defined wall that is made up of granulation tissue only. It is not made up of any epithelium. That is why it is called pseudocyst. This is also adjacent to the pancreas, but usually it is extra pancreatic and no collection, no connection between the cyst and the pancreatic duct. There is no non-liquid component or there is no solid component. Whereas acute necrotic collection and what is walled off necrosis or EOPN. So this is less than acute necrotic collection is less than 4 weeks duration. This also happens in this happens in necrotizing pancreatitis. Heterogeneous collection, that means both liquid and solid elements will be there. And there is no fully definable wall because it is early phase. And this is both intra and extra pancreatic. That means there is connection between the fluid collection and the pancreatic duct. Whereas walled off necrosis means it's more than 4 weeks duration. This is also happens in necrotizing pancreatitis. This is heterogeneous collection containing both liquid and solid, but there is a well-defined wall is there. This is having both intrahepatic and intrapancreatic and extrapancreatic. That means there is connection between the cyst and the pancreatic duct. This is the algorithm you are seeing in all my slides because my talk today is based on this algorithm only. So A is defining what is the etiology and the clinical features in walled off pancreatic necrosis. And B is it is showing what investigation you have to do and it is defining the two types of the walled off collections. That is, one is what is pseudocyst and what is walled off pancreatic necrosis. So that is the definition. And C is how to approach this case, how to manage it. If it is asymptomatic, what you have to do. If it is symptomatic patient, how to manage them. So these things are described by the C and the D part of this algorithm. I request my viewers to pause the video and please read this algorithm because this talk of mine today is based on this algorithm only. So coming to the clinical features, these patients will have the symptoms of the walled off collection or the collection. Yeah, naturally there will be a swelling in the epigastric region. Patient also may have, because of infection, they will have fever also and pain also may be there because of the infection. Because this swelling may compress the nearby stomach outlet, that is, it will go for gastric outlet obstruction. Naturally, the patient may go for nausea, vomiting, or inability to tolerate peroral feeds. Because of this swelling will compress the nearby stomach. Patient may go for jaundice because of compression of this mass over the bile ducts. Bile ducts will be compressed by this collection. So that is why the patients are going for jaundice. And worsening of abdominal pain is also another symptom. If it erodes the nearby blood vessels that cause GI bleeding. If it rupture into the peritoneal cavity, this cyst, that will create the ascites. And sometimes, okay, this can erode into the mediastinum and it will rupture into the pleura, causing pleural effusion also. Coming to the investigations, to begin with, you can do an ultrasound to confirm whether your patient is having pseudocyst or not. Because if somebody is coming to you after a history of acute pancreatitis, 4 to 6 weeks after that, with a swelling in the epigastric region, So you have to do an ultrasound to begin with to confirm pseudocyst, and after that you can do CECT or MRI of the epigastric region mainly to confirm this walled-off collections. This shows the exact location and size of both the pseudocyst and the walled-off pancreatic necrosis. UUS or CT guided fluid analysis also you can do if the diagnosis is doubtful or you want to rule out any infection. That fluid analysis will show low carcinoembryonic antigen if it is just walled off collection. But if it is a cancer, cystadenocarcinoma, then the CEA will be elevated. High amylase level if it is a walled off collection, and amylase will be low if it is cystadenocarcinoma. The gram stain and culture may be helpful to find out the what type of infection these patients are having. So this is the CT scan you are seeing, and this is the typical pseudocyst of the pancreas. Here you are seeing it. The CT finding of the pseudocyst include this shows a round or oval fluid collection which is homogeneous with a thin, barely perceptible wall or sometimes rarely thick wall that shows evidence of the contrast enhancement. Here you are seeing a wall that is made up of only granulation tissue. It is not a true wall. It is not containing any epithelium. They develop most often as a complication of acute or chronic pancreatitis or secondary to any pancreatic trauma or any surgery. So this is a classical picture of pseudocyst of the pancreas, CT picture. So you can do CECT and MRI of walled-off collection that shows the exact location and size of both pseudocysts and walled-off pancreatic necrosis. Here in this CT, you are seeing the walled-off pancreatic necrosis that includes a encapsulated collection. Here it is a encapsulated collection. You can see the cyst wall clearly, and this is having a heterogeneous appearance. That means you are seeing the liquid, pure liquid above. This is the number 2, and below this you are seeing the debris. That is the solid element. So that is nothing but both the debris and necrosis you are seeing here. So this is a case of walled off pancreatic necrosis. This is not pseudocyst, and this is heterogeneous in nature. You can also do MRI for this, where you can see the pseudocyst. See, clearly you can see a round or oval fluid collection, which is again homogeneous with a thin wall, you can see. So this is, if you are seeing a homogeneous appearance, that is pseudocyst. If you are seeing a heterogeneous appearance like that, that is the walled off pancreatic necrosis. Pancreatic necrosis usually will be having a connection into the pancreatic duct, whereas if it is a pseudocyst, usually there won't be any connection with the pancreatic duct. So coming to the complications of the pseudocyst, okay, if the cyst get infected, okay, it will go for pancreatic abscess, or eventually the patient may even land up with systemic sepsis with septic shock. If the cyst ruptures into the gut, patient may go for gastrointestinal bleeding or internal fistula. If the cyst ruptures into the peritoneum, okay, the patient will go for ascites and peritonitis. Because of the mass effect, this will produce pressure effect. If it is obstructing the biliary tract, the patient will go for obstructive jaundice. If it is compressing the bowel, patient may go for bowel obstruction, including either the gastric outlet obstruction is more common, and sometimes because of it can also produce pain, especially if it gets infected. Erosion into the nearby blood vessels will produce hemorrhage into the cyst and sometimes hemoperitoneum. No, you have to rule out this walled-off collection from cystic neoplasms of the pancreas, especially cystadenocarcinoma of the pancreas. How to differentiate from the neoplasm? By history alone, if the patient is having a previous history of acute pancreatitis in the recent past, then you have to think of pseudocyst of the pancreas or the walled-off collections. The appearance on computed tomography and ultrasound is very characteristic. Yeah, that also you can see. You can see either a homogeneous or heterogeneous appearance. If it is a pseudocyst or the walled-off collection, and you can have a characteristic feature if it is a neoplasm. Fine needle aspiration of the tumor or the fluid, preferably under endoscopic ultrasound guidance, can be done. And this fluid analysis, the carcinoembryonic antigen will be very much increased if it is a mucinous tumor arising from that is the cystadenocarcinoma. Amylase level is usually high if it is a walled-off collection, but it is very occasionally only it is increased in case of the neoplasm. And the cytology is also very important. You can send it for Papaniculo stain for any cancer cell. Yeah, this is also very important. So coming to the treatment of these patients, if patient is asymptomatic, then we can do expectant management or conservative. What we have to do is watchful waiting. Consider CECT every 3 months until the whole swelling going for resolution. If patient is symptomatic, then you can do 3 types of treatment. One is you can do endoscopic or minimally invasive treatment, where with endoscopic ultrasound guided, you can go for cystogastrostomy or cystoduodenostomy. And if there is lot of necrosis of the pancreas, you can also do necrosectomy. You can put a drain from the walled-off collection through the nose. This is called nasocystic drain. You can put. You can also do a ERCP and put a peritoneal duct. Pancreatic duct stent. You can put. Another treatment is, of course, the open surgical treatment. You have to open the abdomen, that is laparotomy, then open the anterior wall of the stomach, and then you connect the cyst with the stomach wall, the posterior wall. This is called cystogastrostomy. Suppose if the cyst is in the head of the pancreas near the duodenum, then you can do what is called cystoduodenostomy. Suppose if the cyst is near the tail of the pancreas, then you can do cystojejunostomy. Depending on where the cyst is located, you can do either cystogastrostomy, cystoduodenostomy, or cystojejunostomy. Of course, because it is an open procedure, if there is necrosis in the pancreas, you can also do pancreatic resection. If patient is also having a pseudoaneurysm, better ask the interventional radiologist to do the therapeutic embolization. That you have to do first, and then only you have to treat the walled-off collections. So endoscopic treatment, you are seeing the picture here. See, endoscopy, you are putting it inside, and with the endoscopic ultrasound, you can put 2 catheters here. Yeah, that is what you are seeing in this picture. So this is a double pigtail catheter. You can put, this is the stomach and this is the cyst. With the endoscope, you can introduce this one so that whatever collection is there inside, it will get drained into the stomach. So this is what you have to do. And next thing is, here you are seeing percutaneous treatment, where especially if the cyst is near the tail of the pancreas, okay, under ultrasound or CT guided, you can put a you can put a pigtail catheter and drain it into a bottle outside. But usually, if it is a WOPN or walled off pancreatic collection, usually that cyst will be having connection to the pancreatic duct. In that case, if you are going to put a percutaneous drain, this will result in pancreatic fistula because this cyst has a connection with the pancreatic duct. It will never heal. So we won't put, percutaneous drainage for walled off collection. Whereas if it is a pseudocyst without any connection to the pancreatic duct, then we can try this percutaneous treatment of the pseudocyst of the pancreas can be done. Because then, because there is no connection with the pancreatic duct, patient won't go for the pancreatic fistula. So here you are seeing the open surgery. If the cyst is lying in the lesser sac, just the posterior aspect of the stomach, you have to open the peritoneal cavity, open the anterior wall of the stomach, then open the posterior wall of the stomach also. If you open it, okay, this is nothing but posteriorly you are having that collection in the lesser sac. And then you have to suture this one with the cyst wall. That is why you have to wait for 6 weeks before doing this cystogastrostomy. Because majority of these pseudocysts will resolve spontaneously. If the cyst persists even after 6 weeks, then only you have to do this surgery. Cystogastrostomy you can do if the collection is in the lesser sac. Suppose if the pseudocyst is lying in this area, head of the pancreas, you can do a surgery called cystoduodenostomy. Suppose if the collection, this is what you are seeing as a diagrammatic manner, they are doing the, connection between, this is what is called cystogastrostomy. Suppose if the cyst is lying near the tail of the pancreas, then you can connect this cyst to the jejunum here. That is cystojejunostomy. All are open surgery. If pancreas is having any necrosis, then you can do necrosectomy also because we have opened the abdomen already. You can do that surgery also along with this, this surgery. So coming to the mind map for the walled off pancreatic collection. So you should know the two types of walled off pancreatic collections. That is pseudocyst, which is a homogeneous collection of only fluid. Okay, and there won't be any definite cyst wall made up of epithelium. Whereas in walled off pancreatic necrosis, this is a heterogeneous collection of both fluid and solid. Usually this will have a connection to the pancreatic duct. Coming to the etiology, this could be because of acute pancreatitis, chronic pancreatitis, or pancreatic trauma. Coming to the clinical features, patient will definitely have a swelling in the epigastric region, and if it is frankly infected, patient also will be having both pain and fever. Because of the compression of the stomach, the gastric outlet obstruction, patient will go for vomiting and they cannot tolerate peroral feeding or the food intake. If the swelling or the cyst compress the bile duct, then patient may go for jaundice. If the cyst erodes the nearby blood vessel, patient will go for GI bleeding. And if the cyst rupture into the peritoneal cavity, patient may go for ascites and even peritonitis. Coming to the investigation, to begin with, you have to do an ultrasound preliminary investigation. And if you want to confirm the diagnosis, better do a CECT or MRI of the abdomen to find out the exact location and the size of the cyst. You can also do endoscopic ultrasound or CT guided fluid analysis from this walled off collection to find out exactly what it is, and especially to rule out cystadenocarcinoma. Coming to the treatment, there are three types of treatment. you can either opt for endoscopic treatment, that is your cystogastroscopy, or cystoduodenostomy. You can put double pigtail catheter between the cyst and the stomach, or between the cyst and the duodenum. And the open surgery, depending upon where is the cyst, you can do either cystogastrostomy if it is in the lesser sac, cystoduodenostomy if it is in the head of the pancreas, or cystojejunostomy if if the cyst is near the tail of the pancreas. You can also do percutaneous drainage, CT guided drain. You can put pigtail catheter, but this you can do only for, better to do only for the wall of pancreatic necrosis. You should not do it because that is always having a connection with the pancreatic duct, whereas you can do the percutaneous drain for pseudocyst of the pancreas, where usually there won't be any connection between the cyst and the pancreatic duct. So thank you very much for watching this video. If you think that these videos are really helpful to you, kindly subscribe to this channel and share these videos in your social media. Kindly click the bell button also to get notified regarding my latest uploads. Thank you once again for watching this video. Let us meet in yet another episode. Until then, bye-bye.